All right, what I'm talking about here is going to be infertility, and I am reading this because it's helpful for me to talk things out, and hopefully it's helpful for some of you to hear it. So, 80% of couples achieve conception within 1 year. So, a lot of times couples will say, oh, I've been trying for 2 months and I can't get pregnant. You don't worry about that because 80% of those people, give it another 10 months, are going to have a kid. So most of the time, messing around, trying to give them hormones or perform surgery or something is totally pointless because it's going to be fine in a few months. So after a year, then you start worrying a little bit, maybe. Even then, no. Okay, so a couple is considered infertile after attempting, but unsuccessfully, to achieve pregnancy for 1 year. So you can't even consider yourself as being infertile unless you've been trying for at least 1 year, okay? Primary infertility is when it occurs without any prior pregnancy, which totally makes sense because you've never been pregnant before, and so therefore you have primary infertility. But secondary infertility is when, previously you were able to conceive and have a child, but then now you can't. So it's been over a year since you've been able to have a child and you've been trying actively for a year. So that'd be secondary infertility. Infertility can result from one major deficiency, like a tubal occlusion, or from many minor deficiencies. So there's lots of things that can cause infertility. Infertility has multiple causes in about 40% of infertile couples. So a couple comes in, they say, we're trying to conceive, we can't conceive, it's been over a year. You might find a number of things. You might find, she has adhesions, and he has low testosterone, or he has, some other condition, or she has some other condition that might be causing it. There's usually several things, like polycystic ovarian syndrome, or, whatever, several different things. So that's almost half the time. There's multiple problems. So even when normal fertilization occurs, an estimated 70% or more of embryos are abnormal and fail to develop or become non-viable shortly after implantation. Which is saying that even if, there's not really any, I guess you'd say, issues preventing them from conceiving, out of those, 70% of them, the embryos themselves have got something wrong with them, or they just don't develop, whatever. So that can a lot of times be the problem too. So one of the biggest things, though, that's contributing to infertility is increasing age. So if you look at this chart, after the age of 35, certain conditions such as trisomy 21 really start picking up in the probability of that occurring. But there's other problems too. So this is because of lowered embryo quality, reduced ovulation, and possibly decreased frequency of sex. People get older, they have sex less often. For this reason, it is appropriate to start basic evaluation of fertility at 6 months in older patients. Consider starting treatment for unexplained fertility earlier in women older than 35. What they're saying here is if you've got a girl coming in, she's 19 years old and just got married, and she says, I've been trying to have a kid for a year. You're like, okay, it's been a year, I'll take you seriously now, because 80% of people are able to conceive after a year. But if this is a woman who's, let's say, 37 or something, or I guess in this case older than 35, she doesn't have a lot of years left to conceive. So waiting a year is really a big deal. So when they're older than 35, it's fine to start really evaluating and checking to see if something's wrong after 6 months. You don't have to wait for them. You don't have to wait a year of infertility or of inability to conceive in a person older than 35. If that makes sense. So basic evaluations. So first 6 to 8 months of evaluation generally start with simple, non-invasive tests. So things that aren't going to be cutting them open, just checking probably hormone levels, those sorts of things like that. It says a hysterosalpingography, or radiographic evaluation of a tubal pregnancy. So what they do is they put some, if I remember correctly, is they'll put some dye up into the uterus, and it travels up through those fallopian tubes and goes out to the ovaries, and just kind of making sure that there's a clear passageway for that egg to travel down where it can meet up with the sperm and implant in the uterus. And so they might perform one of those earlier on there, somewhere in that 6 to 8 month period, to see if in fact there is a tube that goes all the way through to the ovary. Because if there's not, that right there is your problem. And sometimes infections like chlamydia or gonorrhea infections can cause some scarring and adhesions that prevent an opening going from the ovary to the uterus. And if that's the case, that's your problem right there. Let's see, the problems causing infertility can be categorized into 5 basic categories, or simply labeled as idiopathic. That doesn't follow into any of them. Okay, so basically you have these 5 categories, one of them being idiopathic. So what are the 5 categories? It's going to be summarized in the chart at the end. So I'm going to go ahead and flip down to that chart right now. Summary of the lecture. Oh, okay, here they are. So first one, male factors is what they call this. This is 20 to 40% of the time, so a little less than half the time. You do a semen analysis, and you're going to find that there is maybe there's going to be some anti-sperm antibodies or something like that. But anyway, you're looking at the semen to see if the semen is able to conceive a child. And what's the treatment option going to be for that? I don't know what that means. It says IUI with wash sperm, IVF-ET with, okay, whatever the heck that means. Okay, so I think this is just intrauterine implantation, maybe that means. I think what they're saying here is what you'll do is you're going to take the male sperm, and then you're going to take the female's egg, and you're going to possibly even inseminate it right there, or maybe you're going to get some donor, maybe the sperm from somebody else. You put that on the egg, and then you implant that right into the woman, into her uterus. So comments, it says frequency of coitus, which means sex, without the use of toxic lubricants should be determined. So you got to make sure these people are having sex without toxic lubricants. Paternal age could be a factor in miscarriage. So if the guy gets older, it increases the likelihood of miscarriage. Female factors. This is a little bit the majority of the time, 50 to 60% of the time. So first one is going to be ovulation problems. So remember, there's this whole process of ovulation where there's luteinizing hormone and follicle-stimulating hormone, estrogen and progesterone, and they all have to rise and lower at certain times. The first period is the there's a secretory period, and there's the proliferative is the first period, and then the secretory is the second half. And that's where, the different things happen that allow the baby to implant. So with ovulation problems is the mid-luteal serum progesterone, which means the levels of progesterone in the blood. It's going to be one problem. So if they don't have enough progesterone at the appropriate time, then the body is going to reject the placenta that could be growing. There's luteinizing hormone predictor kits, which you can find out when is the person ovulating. So usually when the person ovulates, they're going to get a spike of luteinizing hormone, and they've got serial ultrasounds. You can see what's going on there too. See what's happening on the ovary, I'm guessing, to see if there are, in fact, ovaries that are enlarging. All right. Other things you can do, I guess, treatment for this, treatment options, is clomiphene. They call this Clomid. The clomiphene citrate or letrozole with or without human chorionic gonadotropin trigger for ovulation. So essentially what this clomiphene or Clomid is a partial estrogen agonist. And the way it works is normally when you give estrogen, it has kind of this inhibitory effect as it goes back to the part of the body that releases the luteinizing hormone and the follicle-stimulating hormone, and if you have high estrogen, it kind of turns off the luteinizing hormone and follicle-stimulating hormone, which then would stop the person from actually ovulating. And so that's why in the first bit of time with the pill that people take to anti-conception pills, estrogen has this inhibitory effect. But if you give a person Clomid, it's only a partial agonist of estrogen, and so it increases these hormones. And if you increase those hormones, then the result is going to be that the person really is going to have powerful hormones triggering eggs to fertilize and come down and everything, and that's a good thing. So basically, you give them this Clomid, and it can help. Also, you can get a donor egg, and all these other things you can do. Okay, so some comments. It says tests for ovulation are indirect and may be falsely positive. The only absolute proof of ovulation is pregnancy. That's a good note. Okay, next part of this table says anatomic uterine tubal problem. So sometimes the problem isn't with the sperm, and the problem isn't with the what was that word again? Ovulation. Sometimes the problem is with the actual anatomic the ability of the egg to travel from the ovary down to the uterus or something like that. And they call these anatomic uterine tubal problems. So one of the first ones here is a hysterosalpingogram, and this is where they're looking to see if the person has that clear path I explained earlier. It's a saline infusion. They can use a sonography, which is like an ultrasound. They can use a hysteroscopy, meaning they can shove a little camera up in there and see what's going on, and or they could even open it up with a laparoscopy. And treatment here is going to be tubal anastomosis to reverse sterilization procedures, and tuboplasty for tubal damage. Okay, so there's some treatment they have there. Comments on this is that when laparoscopy is performed, the tube should be tested for patency. Recent higher EVF ET success rates make IVF, in vitro fertilization, preferable to tubal surgery. So it's better to just do in vitro fertilization than it is to do tubal surgery if the person has an anatomical problem. Is what I think they're trying to say there. Okay, so if the person doesn't have, if they don't have a male factor and they don't have an ovulation problem, they don't have an anatomic problem, well, maybe they have a peritoneal problem. And example, this would be like pelvic adhesions or endometriosis, that sort of thing. Endometriosis is where the endometrium is in places where it's not supposed to be. So they basically have menstrual cycles in places other than their uterus, and it's very painful and sometimes, and can also cause infertility. And adhesions is where the person has essentially tissue is growing together with tissue in places where it shouldn't be, and that can also cause problems, and that can also be very painful. So laparoscopy with chromotubation as part of the infertility workup, something you can do there. So ablative procedures include electrocautery laser for endometriosis, where basically they go in and they just fry the endometrial tissue that's growing in the wrong place, and lysis of adhesions. They cut up the adhesions. And medical treatment for endometriosis is apparently there's some link there. You can see this stuff. So you can also do in vitro fertilization, which is going to increase the likelihood of conceiving. Surgical removal of endometriomas may compensate ovarian reserve. So sometimes also you can take care of it that way. Cervical mucus problems, spin bark heat, postcoital test, Sims Huner cultures for suspected infections. So sometimes you have to have cervical mucus can help things, or if you have the wrong consistency or whatever, it can cause problems too. So some things you can do there is an IUI with washed sperm. So that's intrauteral implantation, I believe. So you kind of prepare the sperm and then you directly put them in the egg or whatever. So treatment for detected infection. Also, so that's if they do have an infection, take care of it that way. Postcoital test may not post-coital test not performed by many practitioners because of low predictive value. So I guess that doesn't make a big difference. And then the last one is kind of the idiopathic or the unexplained infertility, and that's 10 to 15% of the time. They just don't know why the person's infertile, but they are. They do a laparoscopy to confirm diagnosis with negative findings. So we've ruled out everything. We don't know what it is, but for some reason you still can't get pregnant. Ovarian stimulation, in vitro fertilization, donor insemination. These are all different things you can do, or adoption. Okay, so we went through the 5 possible causes now. Go back to the document where we were. Alright, those are the 5 different categories. So, alright, male coital factor. Or in other words, male problems. So we're getting a little bit more of an overview here. So obtain the history of any previous children fathered, previous trauma or infection. So you want to find out, is this man, has he ever been capable of having a child? So you want to get that history. Because if he has, maybe it's not the man's problem, or maybe there's some new development here, and that would maybe narrow down your differential. Post-trauma or infections, previous exposures like lead or cadmium or radiation, chemo or whatever, excessive alcohol or smoking or medications. Get the semen analysis after 2 to 4 days of abstinence. I think that means you don't have sex for 2 to 4 days and then you look at the semen. Normal semen analysis, the volume should be 2 to 5 milliliters, sperm count greater than 20 million per milliliter, and sperm motility should be greater than 50%. White blood cells, less than 10 per high power field. More could indicate some sort of infection. Lots of variability, so accurate diagnosis of abnormal semen requires at least 3 analyses. Treatment. Talk to patient about frequency, timing of intercourse. The lubricant is used, make sure it is non-toxic to sperm. Reduce, stop smoking and alcohol, so those things make people more likely to be infertile. Discourage anything that will raise scrotal temperature, like a sauna, hot tub, or tight underwear. And injections of human menopausal gonadotropin may be effective if cause of low sperm density or motility if is from hypothalamic pituitary failure. Bromocriptine, dopamine agonist, is for hyperprolactinemia caused by infertility. So sometimes these men will get this tumor, it's a prolactin tumor. Well, prolactin is what causes women's breasts to enlarge and produce milk. And prolactin also goes down and has this inhibitory effect on luteinizing hormone and follicle-stimulating hormone, which in men is what makes sperm, and in women is what allows the eggs and follicles to grow. Follicles, I guess. So if a person has one of these prolactinomas, men will start to get breasts, women will get larger breasts, but they also can't have children. So that's not a good thing if you're trying to have a child. And you give them bromocriptine. See, the inhibitor of prolactin is dopamine. So bromocriptine is a dopamine agonist. So you basically give them dopamine, and the dopamine is going to inhibit hopefully, is going to inhibit the prolactinoma, and it's going to allow them to hopefully become pregnant. So, in vitro fertilization, is only 1 motile sperm per egg is required, and let me turn that off real quickly. There you go. In vitro fertilization, so 1 sperm is required for intracytoplasmic sperm injections. So ovulatory factor, if cycles are regular every 22 to 35 days, the woman is usually ovulating. So these hormones are work in a specific timing. There's the first 14 days and the second 14 days, and then there's this period where she's bleeding, and if this is normal, then you think, okay, she's probably ovulating. But if it's irregular, then there's something wrong there. Investigation's simplest screening test is measurement of urinary luteinizing hormone to assess the duration of luteal function, and the mid-luteal serum progesterone level to assess for level of luteal function. A luteal progesterone level greater than 5 indicates ovulatory activity. So if the progesterone is greater than 5, this indicates that that's good. An inadequate luteal phase may cause infertility. So if you don't have enough of a luteal phase there, then that might be a luteal phase defect or something, and the person probably won't be able to be that would cause them not to be able to be fertile, even if ovulating is occurring. In other words, progesterone has to be there to maintain that baby to stay in there, and if it isn't there, then that egg, even if it comes out and everything, is gonna not gonna result in a child. So how do you treat this? Well, you can give them clomiphene, or you can give them gonadotropins, and that can correct the luteal insufficiency in women with unexplained infertility. Clomiphene, or Clomid, can also be used to treat infertility by polycystic ovarian syndrome. So that's a good treatment for that. Insulin resistance associated with PCOS, or polycystic ovarian syndrome, also can be treated with metformin, which is a really typical drug for people with with just diabetes. So that's kind of interesting. Pulsatile administration of GnRH agonists for hypothalamic amenorrhea. You can give them HMG injections. More available in the United States than gonadotropin-releasing hormone, but increased risk of multiple pregnancies. So dopamine agonists like bromocriptine or cabergoline for hyperprolactinemias. We talked about that earlier. Okay, what about cervical factor? So sometimes it's not the ovary, and it's not the men. It's because the cervix got something wrong with it. So the cervix produces a watery mucus called Spinbarkeit, probably named in Germany, I'm guessing. I don't know. And during the first few days before ovulation, supposed to make this watery stuff that kind of allows the sperm to swim in there a little easier. And the amount and the clarity of the mucus is supposed to be recorded. And this Spinbarkeit can be tested by touching the mucus with a piece of pH paper and lifting vertically. The mucus should be normally in other words, you put it between your fingers and then push apart almost, I guess in this case it's a pH paper. That should normally extend to a thread to at least 6 centimeters, and the pH should be 6.5 or greater. Most practitioners have abandoned this test because the predictive value is low. They don't do it much anymore, apparently. Treatment: treat any cervical infection with a 10-day course of doxycycline. That's a good treatment for chlamydia. 100 milligrams twice daily for both partners. If infertility is suspected to be caused by poor mucus quality, perform intrauterine insemination. Oh, that's what that means. I thought it was implantation, but it's insemination. Okay, uterine or tubal factor. So rarely this is the cause of infertility. It doesn't happen very often. But the diagnosis with abnormalities with hysterosalpingography is where they put the ink up there and they see what happens, or laparoscopy, put a little scope up there. If patency is confirmed, in other words, there's a hole going from the ovary all the way to the uterus, which is a good thing. You want the egg to be able to travel down there. An oil-based dye can be used, and it is often therapeutic in unexplained infertility. So sometimes just doing this can help. The book says if only one tube fills with dye, the HSG should be considered normal, since the dye is usually, but not always, just following the path of least resistance. So if it goes one way, you're probably fine. HSG can cause serious infections. So confirming a normal pelvic exam and prophylactically treating with doxycycline can reduce risk. Remember that any surgical repair of the tubes increases risk of ectopic pregnancy. So ectopic pregnancy is where the egg gets stuck in the tube and then it starts to grow in the tube as if it was in the uterus, and it bursts the tube and it can kill the woman and be really awful. So that's a good thing to repair. Okay, peritoneal factors. Sometimes it's the peritoneum that's got the problem. So laparoscopy, or in other words, put a little camera in there, identifies unsuspected pathological conditions in 30 to 50% of women with unexplained infertility. Endometriosis is the most common abnormal finding. Remember, that was where the endometrial tissue is places where it's not supposed to be. It could be on the ovary or different places like that. If it's in the smooth muscle, they call it adenomyosis, which is a little bit different. Endometriosis can interfere with tubal motility, can cause tubal obstruction, or can cause adhesions that prevent the fimbriae from picking up the released oocytes. So all kinds of problems that can cause that. Substantial adhesions or endometriomas are usually treated with laparoscopic surgery because it doesn't respond well to medical treatment. And then lastly, unexplained infertility, basically couples with documented ovulation, normal semen analysis, and normal HSG Probably a problem with sperm transport, since the IUI with washed sperm appears to increase the rate of conception. So that's why they think that. So like, it makes sense. Anti-sperm antibodies may be another male problem not detected by routine evaluation. May also be caused by inability of sperm to fertilize the egg. That could be the problem. And couples with unexplained infertility also tend to have lower success rates with in vitro fertilization compared to couples with infertility, is caused by tubal problems, for example. And that's the end of that. I hope that was helpful.